Dear students, Assalamu alaikum. The objectives of today's lecture are to learn about renal regulation of potassium, calcium, and magnesium. Renal regulation of potassium. The control of extracellular fluid potassium concentration is necessary because many cell functions are sensitive to changes in extracellular fluid potassium concentration. Normal concentration is regulated at about 4.2 milliequivalents per liter, rarely rising or falling more than plus minus 0.3 milliequivalents per liter. A special difficulty is the fact that more than 98% of the body potassium is contained inside the body cells. Control of potassium distribution between extracellular fluid and intracellular fluid compartments play an important role in potassium homeostasis. Body cells serve as an overflow site for excess extracellular fluid potassium during hyperkalemia or as a source of potassium during hypokalemia. Regulation of internal potassium distribution. After ingestion of a normal meal, extracellular fluid potassium concentration would rise to a lethal level if the ingested potassium did not rapidly move into the cells. Fortunately, most of the ingested potassium does move rapidly into the cells until the kidneys can eliminate the excess. Let's now discuss some of the factors that can influence the distribution of potassium between the intracellular and extracellular fluid compartments. Factors that shift potassium into cells. Insulin. Insulin is important for increasing cell potassium uptake. After a meal. In diabetes mellitus, the rise in plasma potassium concentration after eating a meal is greater than normal. Aldosterone increases potassium uptake into cells, and therefore Conn's syndrome is associated with hypokalemia, and Addison's disease, in which there is decreased secretion of aldosterone, is associated with hyperkalemia. Beta adrenergic stimulation also increases cellular uptake of potassium. Therefore, increased secretion of catecholamines cause movement of potassium from the extracellular fluid to the intracellular fluid by activation of beta adrenergic receptors. Another factor that shifts potassium into the cells is the metabolic alkalosis, which decreases extracellular fluid potassium concentration. Now let's study the factors which cause increased extracellular fluid potassium, or which shift the potassium from the cells into the extracellular fluid compartment. These factors include: number one, metabolic acidosis; number two, cell lysis, because as cells are destroyed, large amounts of potassium contained in the cells are released into the extracellular fluid compartment. Strenuous exercise can also cause hyperkalemia by releasing potassium from the skeletal muscle cells. And lastly, increased extracellular fluid osmolarity can also cause redistribution of potassium from the cells to extracellular fluid compartment. Before studying further details of potassium regulation, let's review some aspects of potassium secretion by principal cells. Secretion of potassium from the blood into the tubular lumen is a two-step process. Step 1. Uptake of potassium from the interstitium into the cells by the sodium potassium ATPase pump. The second step is passive diffusion of potassium from the interior of the cell into the tubular fluid. The sodium potassium ATPase pump creates a high intracellular potassium concentration, providing the driving force for passive diffusion of potassium into the tubular lumen. The luminal membrane of the principal cells is highly permeable to potassium because of two types of special channels in the luminal membrane of the principal cells. These include number 1, renal outer medullary potassium ROMK channels, and number 2, big potassium BK channels. Both types of potassium channels are required for efficient potassium excretion. This figure shows mechanisms of potassium secretion and sodium reabsorption by the principal cells of the late distal and collecting tubules. Big potassium or BK is the abbreviation for big potassium channel. ENAC is the epithelial sodium channel, and ROMK is renal outer medullary potassium channel. Role of intercalated cells. Intercalated cells can reabsorb or secrete potassium. The reabsorption occurs through the type A intercalated cells, and the secretion occurs through type B intercalated cells. There is a mistake in this slide. Factors regulating potassium secretion. Because normal regulation of potassium excretion occurs mainly as a result of changes in potassium secretion by the principal cells of the late distal and collecting tubules, we will study the primary factors that influence secretion by these cells. The most important factors that stimulate potassium secretion by the principal cells include factors stimulating potassium secretion: increased extracellular fluid potassium concentration, increased aldosterone, and increased distal tubular flow rate. On the other hand, one factor that decreases potassium secretion is acidosis, meaning increased hydrogen ion concentration. Now let's study control of renal calcium excretion. Calcium is both filtered and reabsorbed in the kidneys, but remember, it is not secreted by the tubules. The rate of renal calcium excretion is calculated as renal calcium excretion equal to calcium filtered minus calcium reabsorbed. About 99% of the filtered calcium is reabsorbed by the tubules. 65% of the filtered calcium is reabsorbed in the proximal tubule, and 25 to 30% is reabsorbed in the loop of Henle, and about 4 to 9% is reabsorbed in the distal and collecting tubules. Most of the calcium reabsorption in the proximal tubule occurs through the paracellular pathway. It is dissolved in water and carried with the reabsorbed fluid as it flows between the paracellular pathway. About 20% of calcium reabsorption occurs through the transcellular pathway in 2 steps. Step 1 of the transcellular pathway is that the calcium diffuses from the renal tubular lumen into the cell down an electrochemical gradient. Step 2. Calcium exits the cell across the basolateral membrane by a calcium ATPase pump and by sodium calcium counter transporter. So there are two proteins which helps in calcium exiting the cell across the basolateral membrane. One is the calcium ATPase pump and the other one is a sodium calcium counter transporter. This figure shows the mechanism of calcium reabsorption by paracellular and transcellular pathways in the proximal tubular cells. Calcium reabsorption in loop of Henle. In the loop of Henle, calcium reabsorption occurs through the thick ascending limb. Through the thick ascending limb. In the thick ascending limb, 50% reabsorption occurs through the paracellular route by passive diffusion. 50% reabsorption occurs through the paracellular route by passive diffusion. And remaining 50% of calcium reabsorption occurs through the transcellular pathway. Through the transcellular pathway, and this is a process that is stimulated by parathyroid hormone. Calcium reabsorption in distal tubule. In the distal tubule, calcium reabsorption occurs entirely by active transport through the renal tubular cell membrane. In the distal tubule, the mechanism for this active transport involves both luminal membrane and the basolateral membrane. In the luminal membrane, the diffusion is through the calcium channels, while in the basolateral membrane, the calcium exits by calcium ATPase pump and secondly by sodium calcium counter transporter. Factors regulating calcium reabsorption. Factors decreasing calcium excretion, these include increased parathyroid hormone, decreased extracellular fluid volume, decreased blood pressure, increased plasma phosphate, metabolic alkalosis, and vitamin D3. Factors increasing calcium excretion, these include decreased parathyroid hormone, increased extracellular fluid volume, increased blood pressure, decreased plasma phosphate, and metabolic acidosis. Regulation of renal phosphate excretion. Renal phosphate reabsorption. Percentages of reabsorption. The proximal tubule equal to 80%, the distal tubule about 10%, and very small amounts of phosphate is reabsorbed in the loop of Henle, collecting tubules, and collecting ducts. 10% of the filtered phosphate is excreted in the urine. Phosphate excretion by the kidneys is controlled primarily by an overflow mechanism, which means when potassium is more than its transport maximum, the excess is excreted in the urine. Therefore, phosphate normally begins to spill into the urine when its concentration in the extracellular fluid rises above a threshold of about 0.8 millimoles per liter. In the proximal tubule, phosphate reabsorption occurs through the transcellular pathway. In the following manner: phosphate enters the cell from the renal tubule lumen by a sodium phosphate cotransporter, and it exits the cell across the basolateral membrane by a counter transport mechanism. Parathyroid hormone decreases the transport maximum for phosphate, so a greater proportion of the tubular phosphate is lost in the urine. Therefore, increased parathyroid hormone causes decreased phosphate reabsorption and increased phosphate excretion. Control of renal magnesium excretion. The kidneys excrete about 15% of the magnesium in the glomerular filtrate. Regulation of magnesium excretion is achieved by changing tubular reabsorption. The proximal tubule absorbs only about 25% of the filtered load of magnesium. The primary site of reabsorption is the loop of Henle, where 65% of the filtered load of magnesium is reabsorbed. A small amount is reabsorbed in the distal and collecting tubules. Magnesium excretion is increased by increased extracellular fluid magnesium concentration, increased extracellular fluid calcium concentration, and extracellular volume expansion. I stop here and end today's lecture.